Dr. Aaron Motsoaledi returns to the Department of Health, and this has been widely welcomed, with various unions saying he is well placed to address problems facing the sector. Previously served in this position between 2009 and 2019. Motsoaledi has his work cut out for him, especially with the National Health Insurance Act facing legal threats. We ask you tonight on 072-110-5584, should the minister go ahead with the implementation of this policy? If so, how should he go about it? The minister joins us now for more on his priorities for his tenure. Minister, good to have you. Thank you very much for your time.
Good evening, Tabo, and good evening to the viewers and listeners at home. Thank you very much for having me.
Maybe as a place to start, maybe a lot of people would like to know, those who are certainly concerned, do we have the Mpox outbreak under control?
Well, up to so far, we think we have got it under control, even though infections are still growing because, as you know, it is skin-to-skin contact between people. Fortunately, Tabo, it is not like COVID. It doesn't spread like COVID. It spreads a little bit slow because we have got to have a direct physical contact with a particular individual.
And so we are likely to see those who are hospitalized getting better, maybe the number of infections being controlled a little bit better?
Actually, the people who are affected, who are dying, are those who have got compromised immune systems, unfortunately. Usually, people who don't have a compromised immune system, they survive it. It's not really such a very severe disease if your immune system is strong enough.
Right. Let's come back then to you returning to the Department of Health. I mean, if we are to be honest and we look at some of the indicators, even from the World Health Organization, total life expectancy at birth is doing well. Life expectancy of men and women is doing well. Maternal mortality has decreased. Infant and child mortality has decreased. So those indicators pointing to something that is certainly being done right in terms of reducing the burden of disease and to an extent strengthening our health system and the distribution of social benefits. However, in spite of all that, there are still constraints, and one of those constraints being the health outcomes and the distribution of health benefits that vary dramatically across provinces and districts. What is the one thing that you think you can do, particularly to ensure that you impact on that?
Well, let's start with the figures we have mentioned about mortalities, maternal, child, life expectancy. Remember, those things were very, very badly and dramatically affected by the biggest epidemic that we have ever had, the HIV/AIDS pandemic, which, you know, South Africa was the hardest hit in the whole world. We were regarded as number one about the number of people who were infected, particularly because in the beginning, you remember, there was a big argument about how to deal with HIV and AIDS. But after agreeing that we are going to launch the biggest HIV/AIDS treatment campaign in the world with ARVs, we did so. We put the largest number, the highest in the world, of people on ARVs, and we are still continuing to do so. And if you remember, a person no less than Professor Salim Karim said the dramatic change that took place there is equivalent to only one event that took place in our country, the emancipation of slaves. It was like people were emancipated as slaves. Now, HIV/AIDS, while it was affecting everybody, but it was annihilating women and children the most. And that's why maternal mortality and child mortality are improved. Actually, to convince the government in 2009, when I arrived in the department, I showed them the figures of maternal mortality, which were very scary, that we can't live in a country where women and children die like flies because they were the most affected. Yeah. And that's why we were able to stage the biggest program in the whole world. Remember, we also staged the biggest program of testing, HIV, counseling and testing. So that was the success. Now, at the moment, yes, you mentioned something extraordinarily important, the disparities in the healthcare system of the population. Thabo, I'm sure you are aware, anyway, you guys are the ones who emphasize on it, that we are the most unequal country in the whole world. If you want to understand what inequality is, come to the health sector, where we are living in the same country, but certain people get a healthcare system that is like any you can get in areas like Europe, but others get a healthcare. You know, the healthcare system are like chalk and cheese, depending on the size of your pocket. But now you are aware that when God created human beings, in as far as their needs are concerned, their physiology and their anatomy is the same. There's no different physiology and anatomy for the rich and poor. It's the same thing. So it becomes a scandal that when certain people are rich, certain people who are rich, when they need health care, they get the best in the world. When others get sick, they don't get the same. And yet we live within the borders of the same country. That's what we need to bring to an end. And the sooner, the better.
Yeah. Now, one of the things that would have been prioritized, at least by the medium-term budget framework 2019 to 2024, is the question of the NHI. How is this going to be affected in a government of national unity? Was this a red line for the DA that could have been negotiated in the statement of intent, that this is one of the areas that is going to seek consensus?
Well, I was not one of the negotiators, Thabo, so I don't know. But I will tell you straight away, it will be extremely even for anybody to trade with NHI. There are people who believe NHI is a luxurious health system. Like when you want to buy a car and you are choosing a Porsche and they tell you this is luxurious and you don't have enough money and all that. NHI is not a luxury. It's a healthcare financing system that is meant to equalize between the rich and the poor. That's why under United Nations, it's one of the SDGs, the Millennium Development Sustainable Goals, if you remember. There are these Sustainable Development Goals, which were enacted by the United Nations. Universal health coverage is one of them. The World Organization has declared long ago that the only human and sophisticated way of financing health is through universal health coverage, not what you are doing now, fee-for-service, where when you are sick, you need help. Money is suddenly demanded of you. And there are people who you are aware died because they didn't have money.
Yeah.
And so we can't tell the world that we are a democracy and we are a developmental, state, and yet allow people to suffer in this way when others are actually having it big. It can't happen. It can't be allowed to go on.
But your pathway to universal health coverage, unfortunately, is not a clear one. It's almost like you are jumping out of the ZEP fight into an NHI fight. Are you prepared to take this one to the courts?
Well, it's already in the courts, by the way. It's not our choice. On Friday, I sat for 3 hours with the senior counsel who are going to defend the case. There are already 2 groups that has already taken to court, and I'm told that we are expecting many more who are going to take the matter to court, and we are prepared to defend it, because it's not as if we have got any choice. And I'm repeating, Thabo, universal health coverage, or NHI, is a very human system of financing healthcare for everybody. Because let me just give you the figures so that you realize why we don't have a choice. The World Health Organization declared long ago that for a country to have a good healthcare system for all its citizens without discrimination, that country needs to spend at least 5% of its gross domestic product on health, GDP, not on the budget, because people are concentrating on the budget. The universal health coverage is not about the budget. It's about the total wealth of the country. how much of the wealth that the country can generate is spent on health. The World Organization said 5%. Now, South Africa is already at 8.5%. We have far exceeded the 5% recommendation by the World Organization. Countries in Europe are on average at 9%, which means we don't differ much from Europe. Why then are our healthcare system looking like chalk and cheese? Why is our healthcare system so poor? Because of the manner in which that cake is divided. In that 8.5%, 51% of that goes to service only 14% of the population.
Yeah.
And the remaining 49% is servicing a whooping 86% of the population. I mean, that to me is a scandal which every human being ought to see. How do we agree that the healthcare system must run like that and at the same time say we are democracy, we are equal before the law and all that? It can't be. So the issue of implementation of NHI is not a choice. It's something that we have got to do. Let me also add, Section 27 of the Constitution put healthcare as a right. It is a right. It's not something that you do as a favor. It's a right.
Yeah.
But it goes on, the Section 27 of the Constitution, it goes on and say the state must make everything within its powers to make sure that this right is realized.
Yeah.
And subsection 3 of that clearly states no one, and I repeat, no one may be refused emergency medical treatment.
Right.
Do you know how many people never got emergency medical treatment on the roads because they don't have medical aid?
Yeah.
When I was taught medicine, Tab, they told us that when you find somebody involved in an accident or somebody in an emergency, you do certain things and they call them ABC. You check the airways, you check the breathing, you check the blood supply. But in South Africa today, that is not done. There's no ABC. The first thing an ambulance arrives there, if it's from the private sector, they check your pocket. Do you have a medical aid or cash? If you don't have any of those, they leave you right there on the road.
Let's take a break, Minister. Don't go away, because I want to press on that a little bit and get a sense why you have this lack of well-coordinated, holistic, integrated approach between yourselves, NGOs, and other spheres of government when it comes to the implementation of this policy. The minister is facing a lot of challenges in the implementation of the NHI policy, which is what we are discussing. Minister, the own diagnosis of the medium-term budget framework of government says part of the biggest challenges in the inadequate development outcomes in the medium-term budget framework is the process of decision-making. That seemingly takes a top-down approach and does not include a top-down and bottom-up, both, in which you are able to then get contributions from these NGOs and business who are now planning to take you to court and stand in the way of the implementation of this policy?
Thabo, coincidentally, when the ruling party took a decision at the 2007 conference in Polokwane that the country need to go to NHI way, universal health coverage or mandatory prepayment of health, it so happened that 2 years after that conference, there was an election and I was appointed Minister of Health. So for that reason, the job of implementing NHI fell on my shoulders as the minister. And we started developing a white paper first. We didn't just put a law, a white paper, a policy document. I can assure you, we consulted widely on that policy document and we changed it so many times. By the time I left the Department of Health, we were already on the 43rd version. That means we drew version 1, changed it to version 2, changed it to version 3, and until we did a 43rd version before in 2015 in December, we could sign it out as a white paper. Now, all those changes were done because people were giving inputs, objecting to certain things, advising about others, and that is what has happened. And then from there, the bill was drawn up, which, as you know, the president assented into law. in May this year. Now, if there are certain things that need to be changed, so there will be. Even the constitution get changed when there's a need to do so. It doesn't mean there's no law in any part of the country which is cast in stone. You do change things. But what we cannot change is to make sure that the poor also get their good share of health.
Yeah.
That one it can't be negotiated. What will be negotiated is how do we do it? How do we change certain things on the NHI as people are complaining? I haven't met anybody, Thabo, not a single person, unless you bring them to me, who say they are against universal health coverage.
No.
All the people who talk say they don't want this in this present form.
That's right.
So one will have to reason, actually, in what form do you want it? And at the moment, Thabo, the voices we hear are for the well-to-do.
Yeah.
They are voices of people who are gaining from the present healthcare system. We haven't as yet had voices from the poorest of the poor who had a raw deal from the healthcare system of the country.
So
because of the manner
let's talk about what the doctors are saying. You're correct. I mean, in the 3 quadrants of legislative reform, nobody says you mustn't reform legislation. Everybody agrees that you can put some reforms there. There are questions on the 2 quadrants of organized government planning, but most of the people that are spoken to are talking about an enabling environment. In other words, questioning whether or not you've got sufficient capabilities in the system to pull it off.
But are we not running a healthcare system now, Thabo? I've just told you, a healthcare system in which 14% of the population are getting the best healthcare, as best as you could get in very advanced countries, developed countries in Europe. So how are we able to provide that one?
Yeah.
How are we able to provide that one? And when it comes to saving the poor, we suddenly say, no, there's no capacity, there's no capability. Can anybody explain to me how that comes about?
You are doing it very disconnected. In other words, where the impact of resource allocation in the implementation of the policy leaves very little to be desired because it's uneven across the country. So others are saying, yes, hospitals in Gauteng might certainly immediately begin to benefit. But then if you move out into the outskirts of the Eastern Cape and in Limpopo, you'll find that the impact of resource allocation there is not the same as what you find in Gauteng. And therefore, it will be felt more there because the environment is not enabling.
That's exactly why you want a uniform system, which is uniformly financed. Remember that rural areas are far, far behind with development, and urban areas are very developed. And part of what NHI want to solve, as I'm saying, is that inequality between the rich and the poor, and between region and region within the borders of the same country. That's what we want to bring to an end. And it's going to take many years because it's not an event. When we implement NHI, we are just going to wake up and say, here it is. It's going to be something that is implemented in phases and is going to be stepwise, step by step. And it's true. It's true that certain areas will benefit more than others quicker, but it shouldn't be forever. For instance, the healthcare system of Gauteng, Thabo, is the biggest in the whole continent, not in South Africa. I'm talking about the whole continent of Africa. There is no geographic area in the whole continent of Africa where you find the healthcare system as big as that in Gauteng. And so obviously, it can't compare with the healthcare system in my home province of Limpopo or in the Eastern Cape, and or in the rural areas of KwaZulu-Natal, especially in the area north of Tugela River. The area north of Tugela River has got a different healthcare system to the area south of Tugela River, which encompasses eThekwini. So the aim of NHI is to bring all those disparities to an end, and it's something that will take a bit of time.
Now, let's talk about that question again of sufficient capabilities in the system. I mean, there's a story that we are currently carrying, some foreign-trained doctors alleging that they are prejudiced when it comes to their entrance exams, because something that, of course, the HPCSA has come out to say it's absolutely not true. But even before we went into the elections, there were doctors, for example, in the Department of Health in KwaZulu-Natal that were parked outside the hospital saying there is no confirmation about our positions and our posts. We are not being hired. We are qualified doctors. It's not only in KwaZulu-Natal. It's the same here in Gauteng and so on and so forth. So the question of sufficient capabilities when it comes to medical health professionals.
Let's start with the first one about foreign trained doctors complaining about their entrance exam, because we have debated this issue many times when I was in health for the first time. The people who are required to write entrance exams, it's not everybody from another country, are people who are from the non-Commonwealth countries, because our curriculum in healthcare in the country is unfortunately British, because we are colonized by them. So everything we do in healthcare, the curriculum itself, the terminology, the degrees we get, the type of training, the amount of training are all British, because we inherited them from there. Now, different countries train their people in healthcare, their doctors differently. Because if you look at healthcare, it's also very much linked to culture and the mode of the type of life that people are living in. Just to deviate a little bit to explain to you, I once worked in a rural area in St. Rita's Hospital in Limpopo, in Sekhukhune district, my home district. And I met people from Myanmar, doctors, who got lost when they arrived in the labor ward, completely lost. And I asked them, have you qualified? They said, yes, we have qualified. And I said, but why are you so confused? They called me aside and said, look, in their country, there's no doctor, or no male rather, who is trained to touch the private parts of a woman. That is in terms of their religion. So all men are trained only to treat other parts of the body other than the genital parts of a woman. So they know nothing about child delivery. Now imagine that type of person coming to work in your country. That time, it was the Bantustan system. And we can't, in a democracy, allow that. I even recommended then that they must be sent to Medusa, the then Medusa, for training in obstetrics and gynecology, because they say no man studies obstetrics and gynecology in their country. So that's how different trainings are. So for that reason, if you come to a country that is not Commonwealth, because all Commonwealth countries are using the British curriculum, if you come from any other country, you have got to write an entrance exam. And it's the same as medical students are writing in South Africa. So there is nothing that disadvantages anybody. It's just the way it is. You have got to write that entrance exam to make sure that you are not going to kill people, because you must be safe as a doctor. If somebody ought to die, happens to die, it must be that maybe it was inevitable or an accident. It shouldn't be that because we were trained very differently.
And the issue of the hiring of doctors?
Yes, that's very, very unfortunate, Thabo. The issue of hiring of doctors is the fight we have with Treasury every year. And it's an unfair fight, because when you are trained as a medical student, you have got to do internship. It is compulsory, it's mandatory. You can't go, it's not like any degree where you can pass and go and work anywhere. When you have completed medicine, if you can't do internship, you can't go into private practice, you can't go overseas, you can't go and open your own practice. So you have got to do internship, is mandatory, so the state is forced. The unfortunate thing is that every year, this problem reaches a crescendo before there's action from the Treasury, because they say you must use your budget, even when the budget is depleted. There have to be money to put doctors into internship. Else, we must change the system where you go into medical school and after you pass, you can go anywhere. Then that will be better. But because you are not allowed to go anywhere, the state is obliged to give you internship, and that money must come with It's not only training, it must come with your salary.
Let's take some question, a quick one from Ipeleng on 072-110-5584 for Dr. Aaron Motsoaledi, returning to the Department of Health. Here's what Ipeleng has got to say on the question of NHI. We're asking you, should the minister go ahead and how should he go about it? She says, how will the NHI benefit taxpayers? Because all I hear about is equality at the cost of taxpayers' monies. Minister?
Well, ask Ipeleng, who is not a taxpayer in South Africa. Please ask her for me. Who? Which particular human being is not a taxpayer in the country?
So you are saying the taxpayer benefits how then, Minister? The question is that.
What?
The taxpayer, how does the taxpayer derive benefit from the NHI policy?
I am asking you, Thabo, ask her which person in South Africa is not a taxpayer.
I understand
she
that.
Must show one person.
I understand that. What I'm saying is then you need to demonstrate to her how does she also benefit as a taxpayer.
It's going to benefit everybody because everybody in South Africa is a taxpayer. And I want to explain this principle because everybody is missing it. Tax in South Africa is in three. There are three forms of tax. All of them go into the fiscus to run the country and pay for everything. Everything, literally, is paid from tax in the country. The first is personal tax, which you pay by virtue of your income. That's why it's called income tax in other words. It's a personal tax. It is, of course, the biggest. But the second biggest is VAT. Anybody who gets into any shop and buys something, no matter for how much, part of that money goes to VAT, as you know. And even the poorest of the poor pay VAT in that way. The third tranche of tax then is corporate tax, tax paid by companies. Huge mining companies which are making millions, they are paying less than what consumers are paying in terms of the VAT. So every single person who is in the country, if they've ever entered any shop to buy something, they are taxpayers. And you must stop saying only people who are paying tax, personal tax in terms of their income are not taxpayers, because that's the definition I've had. And I'm really challenging it because it's not true. How come that people who are paying VAT are excluded from being taxpayers,
right,
and such that will say, no, you can't get this and that because you are not a taxpayer? It's not true.
Minister, we appreciate your time. Let's leave it there for tonight. That was, of course, an intro. We'll come back and outline some of the other issues with you at a later stage.